Dr. Lenze will be coming back to moderate a discussion with 3 experts in our community who represent different service arenas, starting with Dr. Jameca Woody Cooper is a clinical psychologist, therapist, and educator who focuses on the community, who focuses on serving older adults in marginalized communities in this city and county. Next, Dr. Monique Williams, a geriatrician who focuses on dementia and disparities and works with community health organizations, a network of primary care centers to serve older adults on Medicare, meeting all their needs. And she's going to speak about how mental health comes into that work. And finally, Dr. Katie Holzer, an instructor and researcher with the School of Medicine. Her work focuses on older adults with depression and anxiety in the context of surgery and acute care. So you can see we have 3 different settings, 3 different experts, and Dr. Lenze is going to moderate this, although they're each going to tell them more about themselves and start with overviewing their work. We're going to go in that order. Okay, we good?
Thank you. And if we say anything dumb, it'll be forever saved for posterity. Thanks for this. And look, I just did so. So I'm gonna start with each of you, and just if you could take about 4 minutes to overview your practice setting and then the services that you provide in it, including the common mental health problems you work with, and then really what's unique to your client population and your setting. And if I could start with you, Dr. Woody Cooper, please.
Hi, I'm Dr. Woody Cooper. I am a counseling psychologist, and I've been practicing over 20 years in St. Louis. And first, I'll say a little bit about what I've done in the past 20 years. My practice has been around a long time. I actually started my practice to focus on older adults in St. Louis. Not really intentionally, but I kind of was provoked by some of my friends that were primary care physicians in the area who constantly told me about how their patients needed mental health care. So like begrudgingly, I was like, okay, I'll see a few of them. And kind of morphed into, 20 years later, here I am. And I didn't plan on enjoying the work. I didn't plan on enjoying my work with older adults. So I've been doing that. That's a big part of my practice now. I also am, we all know, I'm sure you know what APA is, the American Psychological Association. I'm the chair of their National Committee on Aging. And we've done a lot of work with the Reframing Aging initiative that they mentioned earlier. I'm also president-elect of the Missouri Psychological Association, and in our state organization, we're working diligently on ways to provide better access for older adults across the state. So in my practice, which is called Emergence Psychological Services, my office is in Clayton, around the corner from the courts building. But as we all know, I do a lot of virtual work. So my practice provides services for individual, couples, family, therapy, and consultation in both inpatient and long-term care facilities, as well as in the community. And that's we've been doing for the past 20 years. It's, of course, very fulfilling work, but there is a shortage of providers in St. Louis. So there's a shortage of providers for mental health. There's a shortage of providers that are people of color. There's a shortage of providers to specialize in older adults. Very few. I can probably count on one hand how many psychologists in St. Louis focus on older adults. So big shortage, not a lot more providers coming through in the pipeline as far as psychologists go, just because many graduate training programs don't focus on that area. So most times I'm overbooked, overscheduled, and long waiting lists because of that. But I will say that I love what I do, and I've been around a long time, and I do understand some of the issues I'm sure we'll talk about in a few minutes with the panel that are really original and unique to the St. Louis area.
Thanks so much. Next, go to Dr. Williams. If you could just overview your practice setting, the services, and your population.
Thank you so much. And before I start, I just have to say that I am an absolute Dr. Woody Cooper fan, having referred many patients to you through the years. I thank you for the transformative impact you've had on patients' mental health and their overall well-being.
Thank you.
And so I want to talk about a few stats and then talk about the Oak Street Health model. So if we look at primary care in general, behavioral health concerns such as depression and anxiety are consistently in the top 5 reasons that patients go to the doctor, what we call a chief complaint or the main concern that brings them to the doctor. And one question is, how common are these mental health concerns among Medicare beneficiaries? About 1 in 4 Medicare beneficiaries lives with behavioral health conditions such as depression, anxiety, bipolar disorder, anxiety, or schizophrenia, but only about 40 to 50% of them receive treatment. As Dr. Lenze pointed out, some of this has to do with access and timing of getting care. Oak Street Health was founded in 2012 as a network of value-based primary care centers for adults on Medicare. And with value-based care, what happens is for the Advantage plans, we take full risk and provide all the care that patients need. We now have 170 centers in 21 states, and we provide care for nearly 225,000 Medicare beneficiaries across those states. And one thing that's relevant is that we focus on quality of care rather than volume. So unlike fee-for-service, where a provider might see 25, 30 patients in a day, our providers typically see 10, maybe 12 in a day, with a focus on really working with a teamed approach of collaborative care to optimize care. So we deliver personalized, preventive, person-centered care with a health equity lens, building our centers in geographic locations where there is a need for medical care. And we use a team-based approach for this holistic patient care. We have longer visit times. Patients can access their providers more often. So the provider and the patient have a dialogue about the appropriate cadence. Somebody who's very medically complex, who might have a big burden of physical and behavioral health issues, might come in every 3 weeks, or might see their doc at the 3-week mark and then have a virtual visit at the subsequent 6 weeks and alternate. We also partner with patients for their wellness plan so that we're really achieving their goals and what they value and honoring their goals of care. We have same day and next day appointments for established patients. We also have expedited new patient appointments. This is relevant because the study from last year showed that with the pandemic, wait time for a new patient appointment, and usually this is when someone realizes, oh, there's a problem, it's getting worse, I need to see a doctor and I need to get a doctor. The wait time nationally is 26 days. In our region, there are some areas where the wait time, for example, if a 80-year-old woman wants to see a woman provider, it may be 6 months. So access to primary care is an issue, but we expedite that. We also facilitate transportation to appointment times, and we have day centers at our clinical settings. So people from the community come in and or our patients can come in, get a cup of coffee, do activities, learn Spanish. One of the things that we're doing is paint and sip because of the cognitive benefits of art. And it's not alcohol, it's mocktails, just to clarify. Because some people got really excited. We're like, don't be that excited. It's punch. But so they come in, they can do painting with using evidence-based activities where they can have general well-being impact on social engagement and cognitive stimulation. We also have integrated social worker, community health worker, and behavioral health services. So our model of care is highly successful. We reduce ED utilization, so emergency department visits and hospitalizations, by greater than 50%. And so we have a behavioral health specialist who's a licensed clinical social worker who's integrated into our clinical model. And the behavioral health specialists provide either in-person or virtual care. Virtual care has been super popular with our patient cohort. And they help to integrate care using evidence-based tools. As Dr. Lenze had mentioned, using measurement-based care, we employ the PHQ-9 and a bunch of other behavioral health metrics to ascertain the effectiveness of the interventions our patients receive. We also have integrated psychiatrists who work for Oak Street Health and can facilitate care. The majority of patients prefer the virtual platform for that as well. And we also have essentially a triangle where the primary care physician works with the licensed clinical social worker, our behavioral health specialist, who helps to facilitate care and also coordinate with the primary care provider with either that Oak Street Health psychiatrist or an external psychiatrist and behavioral health team to really optimize behavioral health care as a component of overall wellness. And one thing that's nice with the system is our providers make internal or external behavioral health referrals to our behavioral health specialist or psychiatry within or without or outside of the system. But we also have an automated system where certain clinically significant parameters on our screening instruments trigger an automated referral. So if somebody does a PHQ-9 that morning and it scores where there's a concern for clinically significant depression, an immediate referral is transmitted to the behavioral health specialist for prompt follow-up. And really, one of the innovations that's been sustained is the utilization of telehealth in our settings. And one thing people ask is, well, can underserved elders use telehealth? And that varies from region to region. One thing that's notable about St. Louis is that although we have some stuff we need to work on in the region, we are doing really well on high-speed broadband access. So actually 90% of households have high-speed broadband access, including dually eligible Medicare beneficiaries. A lot of them love it. And then our library system, city and county, offer platforms. You can check out a laptop with a library card for a year. You can check out a Chromebook and hotspot. You can check out a grandpad. So technology is available. And then one thing that we do at Oak Street Health is that we also can have one of our team members, the medical assistant, the community health worker, or even the provider, the MA might go out to the home and facilitate a home-based visit, or the MA will bring a tablet and do or smartphone and do a virtual visit as well. So we are availing people of some of the innovations in technology. And I just wanted to thank my two colleagues from Oak Street Health for being here today with me. So Carlene Faco, who's one of our practice managers in our Jennings location, and then also from our Jennings location, Arnisa Kalk, who's our community relations manager. Thank you.
Thanks, Dr. Williams. Amazing innovations, really amazing what you can do with value-based care. And I suspect we'll probably get some questions and comments about that. Finally, Dr. Holzer, could you just take about 4 minutes, talk about your practice, or I guess the research setting, the mental health problems faced, and what's unique about the population and setting?
Yeah, thank you so much. And thank you for having me here, Nancy. It's an incredible honor to be on this panel with Dr. Woody Cooper and Dr. Williams. So I am a clinical and academic social worker. I'm in the Department of Anesthesiology at WashU Med School. And then probably the reason why I'm here is I'm also the administrative director of the Center for Perioperative Mental Health. The center is a research center. It's funded by the National Institute of Mental Health and the Foundation for Barnes-Jewish Hospital. It's led by Dr. Eric Lenze and Dr. Michael Avedon in anesthesiology. And the focus of our center is really on older adults who are going to have a major surgery and have symptoms of depression and anxiety. And the reason why we're focused on mental health of surgery patients is because it's really hasn't been a focus before. In earlier models of success in surgery has really focused on the operative problem, the success of the operation, and whether the patient survived. And you'll see over time that there's been more of a focus on the physical health of the person who's having surgery. So early mobilization after surgery, physical therapy, prehabilitation, physical optimization of the patient before surgery, and enhanced recovery after surgery, but really no emphasis on mental health, even though the limited research that's out there suggests that having depression and anxiety before surgery can lead to worse outcomes after surgery, both the short term and long term. So short term, higher rates of delirium, slower recovery after surgery, and in the long term, worse quality of life, readmissions to the hospital, and even death. And these concerns, as you might expect, are exacerbated by age. So they're worse in older adults. So what we really need is a whole patient care, looking at the physical, mental, and cognitive health of patients. And so what we're doing in the center is I work with a very large team of many people who are here today, a team of scientists, implementation scientists who make sure what we're testing is actually feasible and implementable, surgeons, psychiatrists, psychologists, anesthesiologists, pharmacists, pharmacy students, informaticists who help build our research infrastructure, social workers, counselors, patient and caregiver stakeholders, and experts in these areas outside of WashU as well. And what we're doing right now is we're developing, implementing, and testing a wellness program to deliver to these patients, these older adults who are undergoing surgery, and helping them with their anxiety and depression before, during, and after surgery. And like I said, social workers and pharmacists are delivering this intervention that we're testing now. And really, it's just a great time. As Dr. Lenze said, the population's getting older. There's also the number of surgeries are rising, and it's a fruitful and critical time to focus on the mental health of the older surgery patient.
Thank you very much. These are just very, very excellent presentations there. I think if there's a commonality there, something that I really didn't talk about in my talk, it's about the diversity of settings that you deal with. Here I'm thinking about someone who goes from home to hospital to nursing home, et cetera, et cetera. I wonder if you could talk about some of the challenges that you see in that and some of the innovations and strategies either that you use or that we need to address that setting and transition related challenges.
Well, I can start by talking about what I see a lot in my practice and some of the barriers that my patients deal with. Like Dr. Williams just said, is access. Access is really huge. So what does access mean, right? Access definitely means telehealth or telemedicine. And through the pandemic, we've been able to see that shift some. So more individuals are able to receive mental health services that way. However, it depends on who these people are, right? So many of my clients, if they live in the community, depending on their class levels, income levels, might not have a smartphone. Might have a smartphone, might not know how to use the smartphone. Technology may not be their thing. They may not be able to get it together to even click to begin a session, find the app, find the service, those type of things. If they don't have a phone, do they have a tablet, laptop? Those type of things I think most people take for granted because we all have them, but many of my patients don't have them. So access for telemedicine is an issue for those that don't. What if they can't afford the phone or the monthly bill that goes with that? A lot of my clients have the consumer cellular cell phone and bills that go with that. So it's limited data with that every month. So access also means if you can't do telemedicine, can you physically get to the provider? Physical health, medical conditions, and mobility determine your access and the ease of that. So sometimes seasonally, I have patients that can't get to my office for their session and they need telemedicine. So access to me, transportation is an issue if they don't have a car. How are they able to get there? What services can they use? So access there again, I mentioned earlier, providers. The lack of providers in St. Louis for mental health is really pretty bad right now. And Dr. Lenze mentioned some of the numbers, but what we know is that out of the 114 counties in Missouri, 112 of them are deficient for mental health practitioners. And the only two other ones are in the St. Louis area, and those are partially deficient. And living here and seeing what partially deficient looks like makes you think like, wow, what is deficient really? Because we're really at a deficit around here. And there's lots of thousands of more providers that are needed just for the St. Louis area. So access is big, like access to who? Do they take insurance? Many of my clients have Medicaid. Lots of providers no longer take Medicaid just because Medicaid as a provider takes you through everything as far as documentation. And it sometimes does not end up being cost effective. So access is big. Like who do you have to access? Can you access them? What are your services like? Can you get to the services? So many of my clients deal with access issues, really, really big. They also deal a lot with medical, other issues. Dr. Lenze mentioned this earlier, coexisting medical issues like diabetes, cardiovascular issues, autoimmune, cancer. Those type of things is that they are dealing with on top of the mental health, or that the mental health is exacerbating these things and vice versa. So a lot of medical financial barriers are one of the things my patients deal with a great deal. Something as simple as a copay just may not be feasible for everyone, as much as they might need mental health, because ideally I would like to see them once a week, once every 2 weeks, but the copay is $40, $50. That's not in their budget. They don't have any way to get it in their budget. They're on a fixed income. So financial issues are really big. Also familial issues. So they're dealing with their own mental health issues, but then they have older adult children that might be living with them that are really kind of exacerbating their mental health by being a financial barrier or a challenge or expectation that goes with the adult child, maybe grandchildren who also live in the home. So we have the familial pieces of increasing responsibilities and the lack of support that sometimes comes from the family. So many of those things I see in my patients are kind of just in a cycle. They deal with those things consistently. So when we think about why don't people access care? Those are the reasons. Like, can they get to the care? Can they afford the care? Is the care available for them? Do they know how to get to the care? Many times when people call my office to set up something, they'll say, I've called around for months. And then unfortunately they get to me and I'm like, well, I'm not accepting new patients. So then the search continues for them. And like Dr. Williams said, the search could be months because no one is accepting new patients. And then one of the things Dr. Lenze mentioned earlier is the burnout of providers. So because there is a shortage of mental health providers, that means those of us that do practice are extremely overwhelmed and burnt out. And so what I've seen in the past couple of years are my colleagues leaving the field. They're leaving to go do other things like academia. They're leaving to go do corporate, leaving to go do DEI work at a corporation, because this is really, it's too much. It's not what most people signed up to do. When we went to school to train for this, we were told, oh, you'll be seeing this many patients a day and this is what it'll look like and blah, blah, blah. So none of that is true right now. It's not true. And what we expected to deal with was none of this. Like, the complexity of cases is extreme. When I first started my practice and I would see individuals that were older adults and in a long-term care facility, I would tell administrators, oh, well, you can imagine that out of all the residents you have here, 30% of them are dealing with mental health issues. That was 20 years ago. So now we know that out of any long-term care facility, you could probably estimate that about 60 to 70%, if not 80% of all residents in a long-term care facility are struggling with mental health, if not multiple mental health issues. So the numbers have increased dramatically just over a 20-year period. But the outcome of that is that it has overloaded the system in many ways. So lots of challenges that my patients deal with. And so it becomes, like you said, Dr. Lenze, with the psychiatrist, is you're spending so much time managing mental health that it takes your time away from other things. So as a mental health provider, I spend so much time helping them to get connected with community resources, doctors, getting on a wait list, getting medication, that it takes away from my time spent with the mental health. So for everyone that's involved in the system, it creates a problem and a backlog. So I see a lot of that in various ways. I'm sure Dr. Williams and Dr. Holzer will also speak to that.
And I wanted to speak just a little bit about transitions of care. So as Dr. Lenze had mentioned, older patients often are shuttled between different levels of care. And one of the things that's really relevant is that between, say, hospital to a skilled nursing facility for rehabilitation to back to home and primary care, things can fall through the cracks. So one of the innovations that we do at Oak Street Health is that there is a centralized transition team that helps to do proactive communication with the hospitals. Our providers and the nurses in clinic also call in to get updates on patients and provide information and say, we're really your partner for discharge planning, because one of the things that came out of the Affordable Care Act is the concept of having a visit with your primary care provider soon after discharge. And this is to reconcile medications, to make sure, like, for example, if someone was on sertraline and the dose was increased or reduced, we're aware of that. A new heart medication was added because oftentimes people might go in with a cardiac issue and COPD, and they might also be addressing mood while they're inpatient. But all of those are addressed with a medication reconciliation follow-up to kind of review the treatment plan and reinforce what happened in the hospital or what happened in the skilled facility. And so we have both central and local capacity for facilitating that transition, and a lot of communication. The hospital systems understand that we really want to partner with them to facilitate that smooth transition, getting people in post-discharge, with one goal at 72 hours or at least within the week. And then also if somebody might say, for example, I'm still really sore after I'd had that fall, facilitating a home visit or a virtual visit and then having an in-person follow-up visit. So having that communication is really, really crucial, because you could imagine if a patient's meds have been adjusted and that's not conveyed to their primary care provider, neither person's on the same page, Or, for example, if the hospital pharmacy provides meds, so they're not profiled at the patient's usual pharmacy, that can be problematic as well. So having that team approach of coordination of care can really be essential for optimizing care for older adults, preventing rehospitalizations, which the studies show if patients keep up with their scheduled appointments and they keep up with that post-discharge appointment, that can really impact their outcomes, both short-term and long-term.
Dr. Holzer, anything to add about transitions of care and what to do about them for older adults battling mental health issues?
Yeah, no, you did a great job summarizing. And if you can imagine, surgery is kind of like all encompassing of all those issues. It's a really confusing time for patients and their caregivers. And one of my favorite parts of the center is our internal advisory board, which has patient and caregivers on it. And they just kind of took us through the surgery process and how confusing it can be. And really what they told us is having someone to help them navigate all those transitions and handoffs of care is really essential. And whether that be a social worker or a coordinator, and it can be a really lonely time for people. So having someone check in with them, especially when they're at home, they're not able to get back to what they have been able to do in the past, and someone to check in and coordinate with them and advocate for them. And like you said, the medications, that's half of what we're testing in our wellness program is looking at the medications during those transitions, making sure they're not stopping. We've heard from patients that sometimes before surgery, their psychiatric medications will be stopped, and that can be really confusing and scary for patients and their caregivers. And when will that be restarted? And then also being put on those harmful medications that Dr. Lenze talked about in his presentation, that sometimes those are started possibly inappropriately, and working with their outpatient provider and prescriber to deprescribe those medications that could be potentially harmful, and looking at alternatives. But really surgery, you're seeing so many different providers, and it's confusing what the instructions are. And so just having someone there, like a social worker, it can be really important.
Thanks. We have a psychologist, a physician, and a social worker. So a great mix of professional specialties. If I could put you on the spot, if you think about the complex needs of older adults with mental illness and the access challenges that I think Dr. Woody Cooper really nailed down, just how multifaceted that is. What do you see as the geriatric mental health teams of the future, or ideally the present? Who are they made up of? What professions?
I really like what you said, Dr. Lenze, earlier about the team being the physician, a psychiatric or psychological consultant, and then a behavior care manager that kind of manages it all with the patient. I like that format. The structure seems to work well, ideally, if that were to happen. I've, over the years, worked with a lot of physicians, and there tends to not be that component, that behavior care person that kind of coordinates and manages it. So it's the physician referring to the therapist, but without that middle part to coordinate it, make sure it goes smoothly, efficiently. Sometimes that's lost, but I do like that model because it could help get more referrals through. But I also have to highlight, like I said before, that even if we can really tweak the system and make it ideal, then when the system works, who's going to see the people? Like, it's still the provider issue on the other end about we have to get more bodies in the seat to provide the services so that when the system or the model is developed, that it can all work together.
Thank you.
I agree completely. And I would say another element of that is it's going to have to be that multi-pronged team that's providing care and being very collaborative. Another element, and the state of Missouri has been hinting at this gradually. It doesn't get much attention in the media, but Missouri wants to move towards value-based care. They've already implemented value-based care elements for MoHealthNet, from pediatric to adult for Medicaid, and then also as well, they anticipate seeing elements in Medicare as well. So for the program of all-inclusive care for the elderly, or PACE program for Missouri, there actually already is an emphasis on quality metrics that will be implemented. And so that's going to be moving away from the high volume appointments where there's no opportunity to address behavioral health issues in a 15-minute follow-up visit where 5 minutes is rooming in the MA asking questions and checking your meds and confirming your pharmacy. Appointment times are going to have to be longer, and there's going to be a greater emphasis on outcomes and quality metrics. You know, if someone had an elevated PHQ-9 score, what was the response? Did the patient respond to therapy? What's the next process? And really drilling down on both population level outcomes and also individual outcomes for patients.
It seems like value-based care is going to bring maybe bigger teams with team members outside the usual kind of narrow window of who we think about as in terms of practitioners. Finally, I could try to define value-based care, and I'm hoping there are going to be questions about it, but I'm going to hand it to Dr. Williams because she probably does it every day.
So value-based care is a model of care that's based on an emphasis on looking at actual quality outcomes. So not just getting 25 or 30 patients through appointments on a daily basis and looking at volume, but rather looking at individual outcomes. So for example, in value-based care, and we know these elements are crucial. So if you consider, for example, bivalent boosters. So the monovalent booster for COVID doesn't really have efficacy for the current variants, which are kind of like the great grandkids of Omicron. So the bivalent boosters are essential, and they still reduce the risk of hospitalization and death across the age spectrum. And this is crucial because 9 out of 10 people who died from COVID were over the age of 65. If you look at the oldest old, which still to a geriatrician is kind of a kid, because my great-great-grandmother lived to be 114. So I'm like 85 is still youngish. So 85 and older, if you look at that cohort, there's a 340 times greater risk of dying for COVID among that cohort, which is one of the reasons why geriatricians completely freak out about people being up to date on their shots. And it's why, you know, we're disseminating the recommendation for the second booster and that type of thing. So if you look at bivalent booster uptake in a typical fee-for-service care model, it might be like here. If you look at a value-based care model where there's a greater emphasis on patient education and empowerment and access, and, you know, kind of, for example, in the Kansas City market, everybody likes a clinic. Like you do a vaccine clinic, everyone wants to go. It's like there's a sale. It's like there's a big 75% off sale at Macy's. People freak out. They want to get to the vaccine clinic. So if fee-for-service vaccinations for bivalent are here in a value-based care model where there's a greater emphasis on getting to those outcomes, it's much, much higher. So getting the preventative services that older adults need, getting the annual eye exam, intervening on fall prevention, addressing medication management, addressing behavioral health outcomes, all of those have a greater emphasis than just cranking people through. And with that model, you find reduction in mortality, improved quality of life. There was actually a great study that was conducted in another model of care that showed, and we have similar outcomes for Oak Street, but it showed a substantial reduction in both caregiver burden and also in clinically significant depressive symptoms. And it's this multi-pronged interdisciplinary approach that really facilitates it. So it's a different model of care that is much better for the individual and much better for populations.
It's interesting, Dr. Williams, that when asked about value-based care, you turn to COVID vaccine data where we have, good, solid quantitative data about outcomes. But I guess I would, and I'm going to turn things to Dr. Holzer with this question. I guess I would, as a researcher in the field of geriatric mental health, often say, well, where is the evidence? In other words, like if we're going to put together an evidence-based program to improve outcomes, we need evidence for that. So I'll ask Dr. Holzer, what do you foresee as a team for perioperative mental health care? And how do you generate that evidence? And what kind of evidence does that need to be in order to then go to Medicare and say, hey, you should fund this because it's of value?
Yeah, thank you. When you were talking about the team and who should be on the team, I was thinking one of the additions to our center and our wellness program that we're looking at is pharmacists and pharmacy students, and they've just been a huge benefit to our team. They consult with the patients once they come home and look through their medication lists and again, look at those harmful medications that may have been started, that may be appropriate to deprescribe, and then looking at their antidepressants and making sure those are at appropriate doses. So we've heard great feedback from patients that being able to talk to a pharmacist and pharmacy student has been really helpful during this time period. It saves a call to the doctor. It's right there. It's a quick conversation. Just making sure that you're on the, you're taking what you were prescribed and that those are appropriate. So that's been a great addition to our team. And then think about research and testing. So like I've said, we have a wellness program that we've designed and now are adapting for the perioperative setting. And the thing is, there are evidence-based, feasible, affordable psychosocial interventions, and they're definitely underutilized. And we're applying those that we know have evidence that are simple, straightforward to do, such as we're looking at a behavioral intervention called behavioral activation. And again, implementing it to this really strange perioperative setting where people are already really overwhelmed and confused and may find out that they're having surgery the very next day. So there's a focus on post-op. So we are adapting what we can already use and that's already affordable and feasible to this setting and then testing it. And that's how we generate evidence and could make it more widely available if we can show that it works, which we hope and think it does.
And could I add one thing?
Please do it.
Another
And we'll
element
go
of-
to audience questions, I promise.
One other element of the team that I would suggest adding would be having the social worker and the community health worker, because addressing social determinants of health can be really crucial for improving overall wellness and also particularly behavioral health outcomes. So, geriatricians always talk about the medication intervention. So, starting the antidepressant, but also the non-medication interventions, the socialization, shared meals, that type of thing. So you can imagine the older adult who's been isolated during the pandemic, has some mood issues, starts an antidepressant, but they also get other interventions from the social worker and the community health worker in terms of addressing food insecurity or getting them more engaged in the community. And I was actually thinking about one of the success stories in our newsletter for Oak Street, where a woman had depressive symptoms and she'd been very socially isolated, became a patient, addressed, like as Dr. Lenze had mentioned, those central nervous system meds that probably weren't making anything better, better regimen for her allergies, getting away from the Benadryl, getting away from the other medications that were clouding things. She started coming to the center, became a Zumba dancer with the Zumba dancers at that center in New York. And actually with progression with therapy, went from using a quad cane to no cane, and actually went up to one of the docs who was visiting and was like, come here, you're going to do Zumba with me, and was a completely transformed individual. So I think that having that social work and community health work component can be really transformative too.
I wonder if, for those who might not be familiar with the concept, could you define community health worker and maybe say what they would do? Like who would they be and what they would do as part of a team for geriatric mental health?
So with the mental health component, the community health workers can help in a kind of multifaceted approach. So for a lot of patient populations, it can be having that cultural relevance and resonance and congruence, which can be really important. So for example, when I was in Fort Worth, we had a lot of bilingual community health workers who helped to facilitate care and navigation of the healthcare system. So for example, when we had a big mammogram blitz in the winter, a lot of people who are apprehensive about going into the larger healthcare centers, the community health workers helped to facilitate those appointments. One of the community health workers actually had, there was a balloon arch and celebrating your mammogram kind of theme that the health system had come up with that the patients loved. So it's understanding the cultural context of the patient, helping to advocate for them, providing education, and also providing resources. So it's like an augmented type of patient navigation, and some of the healthcare systems actually have really excellent curriculum for the innovations in community health work, which can be transformative for people because you've got someone who understands your experience of diabetes and your community and the barriers in a way that a lot of providers never would.
So someone who may
would
not be a
also add-
licensed professional, but is in the community, shares the values, may have some peer experience.
Mhm.
Sorry, please, Dr. Woody Cooper.
Just to refer to St. Louis, we have organizations, programs that do that. BJC has caseworkers, community health workers, ADAPT. has those as well. I used to be one when I was in graduate school, taking patients, clients to appointments, doctor's appointments, to grocery stores, anywhere else they needed, making sure their chore worker was doing what they were supposed to do and available and present, making sure family support, medical appointments, medications are all consistent. So it's a really important role. But I think they're overwhelmed right now as well with their demographics and the load. But if they could be part of a system, ideally, that would help.
Thank you. I think it would be a good time to move to audience questions, and someone may run around with a mic, or if you ask it loudly enough, I can repeat it too. Or come to a mic, so many options.
Here's a question. We have a couple here, Michelle in the middle. Let's get them to make sure we hear. It's helpful if you raise your thing. We can see your hand a little bit better. Yeah, there's one here and one here.
Should I go? Good morning. I'm Jana Meyer. Dr. Lenze, I've been in your medic study for 7 years. I'm in the mindfulness exercise program, and I am so grateful. Thank you so much. As I listen here, I can imagine that there are a lot of physicians that would think, wow, this really sounds pretty good, but I'm wondering how you're going to get their buy-in. They're going to have to maybe hire people to help.
And thank you as well. But that's for your federal tax dollars at work for the research study through the National Institutes of Health. So you could thank your federal government. But I think, getting buy-in maybe from physicians, I think, for novel new models of care. I think I would guess that Dr. Woody Cooper and Dr. Williams have a lot of experience, some good, some maybe not so good, trying to explain to some of us crusty old physicians these new models of care.
I'll say in my experience, whether it's been inpatient or outpatient care, typically there is a buy-in from the physicians already. They already understand the need of mental health and how it impacts patients' overall physical health and wellness in the long term. They understand that, most of them do. So even for those that understand it and appreciate it, it's the components and the systems and the ease of making it happen. They might not have the staff, the time, the money to start this process of referrals and making sure that patients are followed up with. That could be an issue for some. I've met, I guess, a small percentage in the St. Louis area that simply don't believe in mental health. They don't believe it's that big of a deal, or that it's going to impact their patients' care, and therefore they won't refer patients or collaborate with therapists. But I would say by and large, most of them have the buy-in. But what I've seen most in St. Louis is that even with the buy-in, they simply don't have the time. So they think, like, on this side of their brain, yes, it's very important, but then they're like, I can't make this happen. They're overwhelmed already with their patients and their practices, and they don't see how they can kind of make it fit. So I think probably what would work best is a model, coming with a model in a way that it fits for people, whether that's electronic or something that could speed up the process for them, because I do believe that would impact their beliefs and their readiness to try it. But again, until that happens, I think we'll still see these kind of pockets of people who believe things, but they're over here, whereas other people are doing things over here, and those never connecting. So yes, buy-in is important.
And I would agree. I think the vast majority of providers are receptive to improving mental health and see it as an area of huge need, particularly with the increased burden of behavioral health concerns during the pandemic and following the pandemic. And so when we did content for our Regional National Medical Association conference related to mental health, that was one of the most popular modules. And really the concept of integrating and, integrating care into primary care was an idea. And in terms of accessing virtual, one of the things that was demonstrated was a capacity for using technology that doesn't require the patient to have any skills. So there's a platform called Oscar Senior where the behavioral health team or the primary care team can actually force the consult call through, even if the person can't figure out to hit the green check mark. So you can imagine the person's getting nowhere near the green check mark to turn on their device, but the clinical team can actually override that and create the call, and then the person can't really drop it. So essentially the strings for controlling the device are in the hands of the clinicians. And so that's been a model that some healthcare systems have used. They've actually provided to high-risk patients or medically complex patients to facilitate care.
We're talking about changing attitudes and fitting these models into workflow. Dr. Holzer?
Yeah, I was just going to say, in the surgery setting, we've heard from patients that getting their surgeon's buy-in is really important. And we knew doing a research study that unless we had the surgeon buy-in, that it was probably going to fail. Patients really care what their surgeons say and recommend. And so, yeah, I think the way we've done this and have our clinician champions is just giving them, sharing with them the feedback that we've had from their patients that are really appreciating this extra support during the perioperative period, sharing even just patient quotes with them, but also, you know, those patients who may be calling the clinic over and over with anxiety around their surgery. You know, we're intervening on that. We're having someone that can be an extra person for them to contact and hear from, and extra support system. So that's really how we've gotten buy-in from physicians.
We're hearing a lot of communication, advocacy, a lot of work on our end.
This is just a simple kind of a category question. What's the difference between a senior person that might be home, might be in a facility, but they need memory care or mental health care? Does that overlap or?
Great question. I don't know who wants that. I mean, I could, but who of you wants to take that question?
Oh, I could. What I see a lot of my work is there is some overlap, a great deal of overlap in that mental health, if an individual is diagnosed with or has dementia or any type of memory confusion, delirium, that is a component of mental health based on the behaviors that go along with that and how that needs to be managed by those around them. So lots of overlap with it. There's where the buy-in comes in as well. Lots of times I've seen physicians who don't see the overlap with dementia and mental health. So therefore they don't refer, or they don't feel that this needs to be a part of the care plan or the program, but a lot of overlap. I'm sure Dr. Williams.
Yes,
Yeah.
I agree. And one of the issues too is that for some people, when people develop depression later in life or anxiety later in life, sometimes that can be a risk factor for subsequent dementia down the line. So, and a lot of persons living with dementia do have behavioral health concerns as well. So having an approach that's more comprehensive in addressing both the memory and thinking issues and the needs of that individual, and then also the behavioral health issues that can be superimposed on the dementia, you know, if it occurs near the dementia time, or it could be a lifelong, you know, condition that's been present, is really crucial. And I have to put in a plug for our Greater Missouri chapter of the Alzheimer's Association, because we are really, really fortunate in our region. We have an amazing infrastructure from the Alzheimer's Association in terms of support and resources related to some of the behaviors that might occur in dementia. And they have a helpline that's available 24/7. You talk to a master prepared social worker or other master prepared aging specialist who gives you information, you know, if you happen to call at 3 in the morning or on a Saturday, and then you get rechanneled back to the Greater Missouri chapter, or, you know, if someone's in a different region, their chapter that's local. They also have a lot of education and support for families in terms of both virtual and in-person programs and support groups. So I think it's really relevant for people to avail themselves of those resources, and then also the clinical resources as well.
Dr. Holzer, did you want to comment at all about like the Perioperative Center and how it tries to tackle both mental and cognitive health in one fell swoop?
Yeah, I was going to say the behavioral intervention that we're testing, but also the medication part of this is so general and can be adapted for each specific patient that it really can help to intervene on both the mental and cognitive. I think in one iteration of the center, it was the Center for Perioperative Cognitive and Mental Health, but then we just all encompassed in mental health.
Thanks. It's interesting to hear, you know, a layperson being quite appropriately perplexed by the idea that like mental health is one aspect of, you know, medicine or psychology or what have you. And memory, also the brain, is this totally other aspect with different disciplines, different research organizations, et cetera. It's an ages old duality, mind body duality or split that of course, you know, research has thoroughly debunked the idea that mental health is somehow separate from physical or cognitive health, but just remains to this day. You go to WashU, you say, I want memory care. You go over to neurology. You say, I want mental health care. You go over to psychiatry. So we apologize for the perplexity of it. These three are trying to fix that, but it's an old problem.
I'm a part of the faith community, and it's interesting, Dr. Williams, to see clergy in the community a larger part of your purview. Of course, we deal with issues of a person who has now lost a loved one, going through grief, and that grief, often unattended, exacerbates into issues that lead to depression, et cetera. Loneliness is one of the major issues following the pandemic. People are just so isolated. Dr. Kelvin Adams in the St. Louis Public Schools, we began meeting with faith-based persons, looking at how can we affect families and children in that system. I'm just wondering, in this whole field, how do we take a look at connecting with faith-based issues in communities that do deal with senior adults?
And in terms of addressing with the faith-based organizations, one of the things that can be most relevant is ascertaining what that faith-based group, like if you're looking at, say, a district of churches, or you're looking at an individual religious organization, what are their concerns and preferences and what are their values? One thing that can kind of go wrong from the perspective of healthcare systems or academic medicine getting involved with them is coming in and saying, hey, church ABC, we know this is what you need and we're going to fix it for you. And so coming in with a great level of humility and being able to say, we wanted to meet with you to determine what your needs are. And, you know, it could be for one church, it could be that maybe there's a lot of substance abuse in that community, or, you know, maybe they're seeing a lot of social isolation, as you were saying, and loneliness, and how can that be intervened on? So really doing the legwork to determine what does that religious community want, and then also ascertaining who are the right stakeholders to be involved. Because one thing that's unique about religious organizations across our nation is that there's a hierarchy in politics, and it's never really intuitive. So determining which way to go, the right pathway, so that you have the most impactful interaction is really crucial. So, you know, there are some churches where the gatekeeper might be someone in a health ministry. There's another religious organization where it might be the clergy. So understanding that and navigating that is really important. So one way to get involved in, efficiently is to visit the organization, attend some services, start to interface, see how things work. Or if you get invited to a health fair, getting a foot in that way. But it's really crucial to determine what the community needs. And that's really one of the things that's relevant as we look at advancing science related to, behavioral health and also aging topics as well. Because it's like, for example, if a clergy member is dealing with tons of falls or family dynamics, it's like knowing that that's the crucial issue. Like, there's the sandwich generation is the main concern for that organization. It's relevant to know that. So give them what they want is really important. So for example, whenever I meet with religious organizations, the first time I say, I can give a presentation, I could do a panel, I could do a presentation, I could do a booth at a health fair, I could, whatever you want. And my presentation can be from 60 seconds to a half-day workshop or a full-day workshop. Anything you want, you help me design it and we'll give you what you want.
Our center received funding from the Foundation for Barnes-Jewish Hospital to look particularly at the needs of racially minoritized patients in the surgical population. And we've been running focus groups with African-American surgical patients. And in every focus group, they've said emphasis on faith is so important and involving the faith. And they said they looked at our behavioral intervention and saw in this intervention, we have a list of activities or values, and faith was missing from those. And they said, you have to include faith in that, even if it's not for every patient, that it needs to be incorporated in some way, in some option. And we've heard that across the board. And we're really excited to start implementing that into these interventions.
Yeah, I have a question. I've been paying attention to all these gun legislative things that are going on in our world. And they say that the problem is mental health. We need to fix mental health. From listening to you all talk, you don't have enough people to take care of the ones we have now. How in the world would you ever be able to do that? That's one question. The second question, if I could, if I can remember the second question, hope I can. Okay. Second question is this. Doctor, you said that cannabis is bad for you. All we heard during this campaign to get it on the ballot and get it passed was how good it is for you. Could you help me understand which is the right way to go?
That's. Well, I'll just say this, cannabis causes memory problems. And so that's a short answer, which is usually compelling to my patients. I think your first point, though, gosh, encompasses a lot of issues. Some of them maybe not even specific to geriatrics, but about the role of, I would say the role of violence, but maybe the role of screening and mitigating gun violence by maybe innovative models of care. I would really be interested in hearing what my colleagues say about that. As far as the workforce issue, we cover that to some extent, and there are problems and solutions. But what about the violence question?
Well, violence is huge in the St. Louis area. We've seen a lot of that in the past year. So for us, at least I can speak for myself, my colleagues in St. Louis metro area, and then our state association, we really are working with legislation. So we've met with senators, representatives about bills that are important to mental health. One in particular is House Bill 1098 this year, which is the telehealth bill. Because as it's written now, it does not extend beyond December of this year, and it does not include psychologists all the time. And it also requires that you use certain platforms, which is not feasible for telehealth. So lots of ways we have to get involved with advocacy to even make the policies better so that more people can receive services. But there is a really big issue of lack of providers. That has to be addressed at a really foundation level training, like graduate programs. We need more graduate programs. We need more ways for people to get licensed. We need alternative forms of helping people. The young lady that spoke earlier about the app that she was working on for cognitive assessment, we really could benefit from apps and software that are used to maybe digitally track symptoms. That would make my job a lot easier if I could find out exactly what's going on with my patients when I'm not with them, as far as their mood, their behaviors, what they're doing, so that when I see them, I don't have to spend time asking them questions or them not telling me what the truth is, but I would already know. And then that puts me ahead. I can then do other things. So there needs to be more providers, other ways of helping people, such as apps or other. I can't say I'm a really big fan of AI, all in that way, not ChatGPT. I don't think that should replace therapists at all. I don't believe that. But I do believe that AI, artificial intelligence, can help some of the systems we have. It would help to track symptoms. It would help to monitor symptoms. It would help for basic things like helping you put more practices in. Someone in here mentioned mindfulness and how helpful that's been. I try to get all my patients to do mindfulness, but once they leave my office, they usually are like, oh, what the hell? I mean, like, I don't have anyone here with me to help me. So a training, coach, tracking mechanism, such as an app, would be helpful. because we won't be able to address getting more graduate programs created in the next 5 years. We won't be able to get those programs extended to have more providers to come out, but we can work on those alternative methods.
And just one other comment about cannabis. So nearly half of my family works for the FDA. I know stuff about food and drugs that you don't want to know. But one of the things is cannabis is not legal at the federal level, and it's not regulated since it's not legal at the federal level. So consequently, if you have something that's a supplement, whether it's cannabis or something that's supposed to improve memory, you have no idea what's in it. And based on FDA standards, because they don't inspect the production of cannabis products or other supplements or CBD gummies or whatever, they're not reviewed with the same rigor. So those factories are often not clean. So you could imagine there's something dripping from the ceiling, might be a little bug or rodent poop in the stuff. So not a fan of the cannabis products because it can affect cognition, and because since it's not regulated as a drug, you don't have assurances that it actually has safety, efficacy, the true product, you know, that it's not a little bit of lawn clippings with cannabis or whatever. You can't substantiate that because it's not regulated. Plus the cognition effects can be substantial. And then the other thing is in terms of the pipeline, that's something that's being worked on with a lot of initiatives, like the Friedman Center for Aging does a week that advocates for careers in aging, the Career in Aging Week through the GSA. With my outreach that I've done, actually, because of the fact that people come in with their robots that they can use for surgery and all this fancy stuff that competes with geriatrics, I actually literally go after pre-K and K to try to get people interested in geriatrics. So when I was at WashU, we actually used to do these programs that were for senior kindergartners who were turning 6, and we would talk about careers in aging and geriatrics because we thought we better get them before they see all the glamorous high-tech stuff.
Well, we're at time, and I think we'll all walk away with a visualization of CBD gummies with rabbit poop. So thank you, Dr. Williams, but I want to thank all the panelists. Really wonderful discussion.
Thank you so much for being here. I hope you learned something. I know I certainly did. Please join us outside if you have a minute more for talking to some people and having a snack. And thank you for coming, and we'll see you.
Yes, you can't put it all away.